So I want to talk to you about psychedelic care. It's not necessarily a psychedelic medicine or psychedelic treatment, but various forms of care that involve psychedelics. So I want to start with some disclosures. In the last 3 years, I have had some relationships with people who are developing, entities that are developing psychedelic medicines. I will be discussing non-FDA approved uses of medications in this talk. I'm a signatory of the statement on open science and open praxis for the use of psilocybin and related substances. If you don't know that, I highly suggest you look it up. And if you want to see my research funding for the last few years, it's from these foundations and government entities at the bottom. Here's something you don't normally see on a disclosure slide. So I am talking to you as a psychiatrist, as a scientist who carefully reads the scientific peer-reviewed literature, but I'm also going to be basing some of my comments today based off of my own experiences being with, participating in communities that use plant medicines in traditional ways. I also, as a clinician, have availed myself of ceremonial practitioners over many years to try to answer questions, give education on safety, and provide information that can support risk reduction. And through that role, I've seen a number of cases and heard many of stories of when people have had marvelous, healing, very helpful experiences with these substances. Unfortunately, I've also heard cases where people have had very challenging experiences, either soon after or sometimes a long time after their psychedelic use. And it's this experience engaging with community that largely informs some of the thoughts I want to share with you today. So just to start, I want to just highlight that we do know from a scientific perspective that psychedelics can be helpful for mental health and substance use disorders. If we look at the two largest studies that have been published in the last few years, looking at the use of, for instance, MDMA to treat PTSD, a study of almost 100 patients, a phase 3 study done by MAPS, they found a large effect size that was statistically significant when 3 sessions of MDMA were paired carefully with psychotherapy over several weeks. Likewise, we just had a paper that came out. It was very exciting to see that psilocybin in 2 high-dose sessions, also compared with psychotherapy over several weeks, was shown to be efficacious in people with alcohol use disorder. I highlight this as the best data that we have so far from the scientific perspective of how we can treat diagnosed conditions in patients. But stepping back, what are we talking about? Psychedelic medicines, what are these substances? What do they really do? And then how do we think about using them responsibly? You know, we could think about psilocybin as like a new antidepressant, but I don't actually think that's a very helpful term. Even the medicines we use conventionally to treat depression in psychiatry, the SSRIs, I don't think we should really call them antidepressants. They help anxiety. They help sleep some of the time. They help appetite. They do many things in our system, and so it's often helpful to stop and think about what are they actually doing and not just what's the category that's easy to call them. Likewise, I think with psilocybin containing mushrooms and other psychedelics, I want to propose we think about what do they really do. To prepare this talk on safety and risks with psychedelics, I was asked to present ways that we can think about psychedelics in a fashion that is more robust or more mature than just, are they wonder drugs that cure everything? I don't think that psychedelic medicines can just be a panacea that makes everything go away. It's certainly not the case. But I do think they're wonder drugs in the way that they elicit profound experiences of wonder and awe. And it's something totally different than the current way that we use pharmacotherapies in mental health. And I want us to hold on to that and stick with that and explore that. These data from the 2016 publication from the Johns Hopkins study of using psilocybin and talk therapy to treat distress in patients with life-threatening cancer diagnoses show that the improvement on depression symptoms and anxiety symptoms correlated with the intensity of what they call the mystical type experience. And if you break down what that meant to the patients who were saying, I had a mystical type experience, they reported a loss of normal sense of time and space, experiences of amazement, awe, and awesomeness. We don't hear this very often when we ask people, what is it like when you took your Prozac? Or even a really great talk therapy session, once in a while, but not usually. And so being mindful and really careful about what people are saying they experience and what these drugs really are and these substances and these sacraments and what they can be is important. Now, thinking about the benefits and then the risks and how we really compare that, this is where I really want to think out of the box, because it's not just a benefit of my depression is better, my anxiety has gone away, but we're comparing the risks with these benefits that are ultimate meaning, intensity of experience itself, that's something that people seek sometimes when they take these medicines. Sometimes we come away from these experiences with a profound conviction of meaning, which is not just a product of the substance, but it's where we took the substance and with whom. There's social factors that go into shaping what we find most important in these experiences, and that's something we need to think about in this balance of risk and benefit. I have this quote on the bottom, if I die during a ceremony, don't call 911. This is something I heard that a member of a church said when their friend actually had a heart attack during a plant medicine ceremony in this very experienced group of practitioners. And someone else who had been practicing this way in this community for many years said, I don't want you to involve medical care, because if I'm having that, it's because the spirits are calling on me to come in that moment. And it aligned with their belief system that that was more important than getting into an ambulance. And when I was explaining the story to a member of a federal agency that works in public health, they could not tolerate what I was saying, that people who are going to take these plants for treating their depression might want to go with the spirits. But this is the type of framing we have to stop and think carefully through when people say they're going to seek this out and why. Wonder and awe and amazement, just to pause for a second, can be rather profound and sometimes can also be rather jarring. I was involved in a psilocybin clinical trial at UCSF a few years ago, and one of our participants who came in had never taken psychedelics before, had a rather high dose of synthetic psilocybin, afterwards reported very little change. His symptoms didn't really budge, things didn't really seem psychiatrically that different. The big thing that was different from him, from when I would talk to him, is that for the first time probably in, years, he smiled and he started making friends. So things were moving, but we couldn't really measure it on our scales. And yet, he came into clinic. I heard from one of his providers months later, he came into clinic in tears, asking the psychiatrist, how do I figure out what happens after I die? And can you refer me to some books on ESP? Now, this psychiatrist didn't know what to say. We ended up referring him not from our academic medical center. We referred him to this place called CIIS to go get existential therapy. But he was struggling with what happens after I'm gone, not am I sad, am I lacking motivation, or is it hard for me to get out of bed? So we opened up questions for him that were really hard for him to deal with, and that's something that might not show up until weeks or months after one of these treatments. In this setting, one thing that stands out to me is that this participant did not have community. He did not have people to discuss this with. Even though we did a group therapy study and we encouraged people to spend time with each other afterwards, knowing that connection and shared meaning making can be helpful, he did not avail himself of that and wasn't able to because of his other challenges that he had in his life. And so he was struggling with this alone, which I find a sad thing to say. Now, there's a lot of sort of potential risks and sort of abstract risks, but there's also some very clear risks that as a physician I want to point out. If we look at clinical trials, and if we look at cases published in the scientific literature, we know that patients will come away with what they would report maybe as an adverse event. And this has been talked about by other people here, headaches, nausea and vomiting, perceptual changes that can be distressing and persist sometimes for weeks, if not months, after high-dose psychedelic use, as well as what a number of us have been talking about for the last several months, the vulnerability of people when they're in these states acutely, and some other things that I'll talk about. This is a health risk I want to highlight as something that's theoretical, but I don't want us to dismiss it, just because we know that psilocybin and other psychedelics can be rather safe, physiologically safe much of the time, but there is data showing that, especially at higher doses of at least synthetic psilocybin, that it can change a part of your heart rhythm. So there's this thing we call the QTC interval. Doesn't matter exactly how we measure it, what it is, but you can see it in an EKG, and we know that with some medications, like some antidepressants, methadone, antifungal medications, it can prolong the QTC interval. And in some patients that already have a long interval, if you make it even longer, it puts them at risk of an arrhythmia that can lead to sudden cardiac death. And it is this type of medical outcome which has led to a number of medications being taken off the market because of this concern. Now, it's unlikely that people using kind of typical doses of psilocybin are going to have this outcome. Most people don't. Many people have used psilocybin without having cardiac problems. But at higher doses, in people who maybe have co-occurring medical conditions that put them at risk of this, this is a concern. And there have been case reports of people using psilocybin mushrooms in community settings who have had sudden cardiac death. So it's something to be aware of. Now, even a really bad outcome like that needs to be thought about in the context of the larger picture. How many people use these substances? How many times do we actually have negative outcomes that we are aware of and that we can measure? If we look at the data from SAMHSA, a large public health federal agency, they ask people every year in the last 12 months, have you used hallucinogens? In which they put LSD, ecstasy, mushrooms, PCP, all these things that they lump together. And in 2020, they asked this, meaning 2019 and 2020, we had over 7 million people who are 12 years of age and older in this country say I've used one of these substances at least once. What I find is interesting is we can also look at other health registries that measure adverse outcomes. So if you look at the National Poison Data System from 2019, all the different number of times that someone who went to an emergency room and the doc there called them and said, we have someone who came in who took LSD or whatever, how long do we have to watch them, how do we help them treat them? They registered short of 5,000 cases in that whole year. So if we compare that and assume of all the people who took hallucinogens in 2019 and 2020, let's say they only took it once, that means that less than 0.1% of the time there was an outcome registered in this system that was a major effect, meaning it had a life-threatening situation or led to persisting disability or disfigurement. Less than 0.1% of the time using this metric. It's not perfect. This doesn't capture all of the adverse events with these drugs, but we can start to look at this, for instance, in Oregon, and if we're having much more psilocybin use, we can look at existing data systems to figure out, is it leading or not to enhanced visits to the emergency department or worse outcomes when people need to get medical treatment. It's in the nature, sake of time, I'm going to keep on going. I really like the National Poison Data System. They also specifically ask about psilocybin mushroom use, and we can look at, going back 17 plus years now, all the times this has happened with psilocybin mushrooms, where people had a really bad outcome, and we can track that here in Oregon if we want to see what's happening. There's a few of these sort of more abstract concerns I'll just briefly mention. Others have said, what about drug-drug interactions? I think it's going to be really important for facilitators in Oregon to be asking about what medications people are taking, and that's the only way we're going to figure out if an adverse event does happen, might it have been related to something else that someone was already on. We also really don't know what is the effect of when someone is taking an SSRI and now they take high-dose psilocybin. Some studies say that actually that should decrease the sensitivity to the psilocybin. Some studies say it has no effect. You're still going to have a large psychedelic experience. So we just don't know, and people here will be figuring that out. I do want to highlight that there are cases that I've dealt with and tried to help people with or heard about where people have what seems to be like a post-traumatic stress-like reaction from taking psychedelics. People who have these persistent panic attacks, trouble sleeping, somatic symptoms that can go on for weeks after a classic psychedelic experience, and how the community of providers is going to help people when this does happen is going to be telling for how we sort of step up and take care of people that we're trying to help and find healing, but might not quite find it in the way that they thought they would. And here's a tricky one, and it's starting to come up a little bit in the scientific literature, but this concern of false memories. People will certainly take psychedelics and recall things that they never knew had happened to them in their life, but they are convinced that it happened, and I'm not in any position to tell them whether or not it happened or it didn't. But I do have a concern that when people recollect things that their family members and their close friends and their community members of people who use these same substances say, I don't think that's true. I think you're sort of believing something that you were shown in a vision that doesn't match with reality, but they don't believe that. That can lead to a really stressful clinical situation, and we're going to need to be able to work with people to either figure out that it was true or not, or at least figure out how it affects them and how they want to move forward. We talk a lot about preparation and integration, but what is happening when people take the substance? Are people prepared to do work actively and not just receive and not just take a substance and see what comes up? Can they sit up? Can they engage with the experience? Can they ask questions? Can they protect themselves when things approach them in the experience? And are people being trained to engage with psychedelic journeying in an active way that may be actually protective for them? Different communities of use approach this in a different way. But in a just very fundamental way, I want to say if you're working with someone with not a lot of psychedelic experience, it can be very different from someone who's an experienced journeyer in terms of thinking about dosage, if you're going to be in a group. If I were to lead a group with 4 novices versus 16 really experienced people, it might be much easier to work with the 16 experienced people than the 4 novices, but each provider will have to figure out how they're going to do that safely. You matter. The facilitator matters. It's not just the drug, it's not just the setting, but the things that you do and how you do it, even if very subtle, can make a big difference. When we ran our psilocybin trial at UCSF, we worked really carefully with our phone screeners to make sure that they were warm and welcoming, and then when people made their first contact with us, that they knew that they were going to be in a safe space and that they could be themselves when working with us. And we tried to sort of have that structure throughout their whole experience until the last integration session. Your limits are important. The limits of our intervention is important. I don't want informed consent ever to be thought of something that's a form that you sign. We really work on this in clinical research, and informed consent is an ongoing process of people asking questions, bringing up stuff, and after they do one session and they learn much more about what psychedelics are, that you have an even more in-depth conversation before they work with you again. I really hope people are actively referring clients elsewhere when you're not really sure if you can work with them. That's a skill, and it's going to take learning. It's going to take some mistakes, but doing that well, as we've heard earlier today, this referral network, I think can just be key. And I don't know where all the facilitators are going to get their ongoing supervision for really complex cases. I think it's going to be great when we figure that out. I hope the training programs can provide really good ongoing supervision, but when you're facing a really complex case that you and your friends haven't seen before, these structures are going to need to be developed. And as much as it's really powerful to follow your intuition, you're going to help people, you're going to know what to do so often, it's also really helpful to know when not to just say, trust in the medicine and trust in me. When can you pause and get help? I think will be a really key thing to learn how to do. So to wrap up, stuff happens. Make a plan. Your plan will fail sometimes, and make it better. So when you know you need to call 911 or you're not sure, that is a skill, and hopefully someone can help you figure out when to do that. If you love being in nature and want to do retreats and take people out into the wilderness, great, but you're also taking them further away from a hospital. So hopefully nothing will come up, but even if you just get CPR trained and you know how an AED, you could save the life of the person who had a heart attack when they got to the site and never took any medicine, but actually just needs medical care regardless of what you were planning on doing in the retreat. And then for behavioral emergencies, this is where the local standard of care will be important. When someone who took a high dose of psilocybin gets it stuck in their head that they have to get in the car and drive home and take care of their family member who's calling to them, how are you going to stop them from doing something that's not safe? Because you're probably not going to have emergent meds on site like I do in the emergency room. If I have to, for the benefit of the person, provide them something that will sedate them and help them calm down, I want you to think how you're going to safely talk people down or stop them from getting in that car. I'm going to wrap up because we're getting at time, but it's really important to say trust in the process, trust in the medicine, but I really hope you also trust in peer review. So setting local standards of care, being open about errors and problems when they occur, and having a protected space to talk about them. We have this in licensed medical care where we can get providers together, and you cannot subpoena us and ask us to come to court and talk about what we just said to help each other learn. I hope you guys have something like that. And if we're going to have this brand new system of care where you are seeking guidance from other people, I hope the elders feel welcome. I hope the elders know that we need their help. I hope the elders want to share some of their wisdom and that we're asking for it. So I need to stop because we are over time, but thank you.
All right, so we'll be, can you hear me now? Okay, we'll be taking questions from the audience, and friendly reminder, if you don't know how to submit questions, there's a QR code on the back of your badge that you can scan. Brian, first question, I would love for you to elaborate something you were talking about during your presentation, which is doing case consultations and being able to speak from a space of confidentiality so that all the facilitators and practitioners can improve in a room. How would you think about setting that up in a space like this where we're setting things up from scratch?
The confidentiality piece of the providers is something that comes from a legal structure, right? And so I don't know if OHA can step in and say, even though you're not healthcare providers in this role, the state is going to allow you to have a separate space where we're going to encourage you to openly talk about things, and we will legally protect you from having to come and talk about that in a court setting. But that's going to have to kind of come from up above.
Thank you. And then here's a big upvoted question we've gotten from the audience, thinking about how the facilitator matters. How can we protect against letting predatory individuals become facilitators?
We do background checks in a lot of fields. We try to understand people when we train them. It's hopefully longitudinally so you can observe them, not just when they're in a class, but doing exercises and getting feedback from peers along the way. But I don't think we're going to prevent people who would be bad actors or repeatedly do things they shouldn't from getting certified. I think what's going to happen is that once complaints come, we need a way to take away the certification, right? We need a way to step in and have a system where, in my field as a physician, it's the state medical board, is made up of senior physicians who say, this is the standard, and this is what we have agreed on as practitioners, and we are going to say that you shouldn't do that, and hopefully the practitioners in the community understand and respect their decision enough to listen. So it's going to be about taking away the privilege to act that I think is going to be almost more important than preventing people from getting certified in the first place, because then we'll see what people actually do when they're not in the classroom and being watched.
And then a follow-up question to that, there will be different styles and types of facilitators who will probably be the right fit for different types of people. What would be your recommendation to folks who are looking for a facilitator? How would you advise them to figure out if a facilitator is the right fit for them?
That's one of the beautiful things about doing this work is that there's so many ways. And I think what's important is that, because there's probably not going to be a right way. I don't think we'll ever be able to say that. And as a scientist, I can't say there's only one way to do ceremony or to sit for people when they're connecting with their higher power. But there is a way that we can ask the facilitators to really speak not just from a place of authority of, I think this is good for you, or the medicine inspired me to offer this for you, but I have teachers. Let us know who they are. Let us know what communities you've learned in. Let us know who is it beyond just you that you're channeling through this work, and be very explicit about that. We have a law in California that was passed 20 years ago that legalized the practice of alternative medicine, energy healing, various sort of things that the medical board didn't know how to regulate. But they made it really clear, if you're going to legally do this in our state, informed consent means telling the person about your lineage and training in really explicit terms so they can make that decision, because it can be kind of overwhelming when someone's providing you medicine and transcendence to just sort of know how to judge that. But if you know who trained them and who trained them, that can be helpful.
Okay, another upvoted question. Does synthetic psilocybin give the same effects and properties as psilocybin mushrooms? And if not, why are we using synthetic rather than the mushrooms itself?
I haven't seen a good scientific study that compared these two. I can say I have eaten psilocybin mushrooms, and I've been administered synthetic psilocybin in a clinical trial. There's a lot of overlaps, but certainly there's other compounds that are in mushrooms that are not in synthetic psilocybin, and there's a very different experience that can come from being in a very different setting with a different intention. I'll say that the clinical trials that have been done to date have been done with synthetic psilocybin because you have to get FDA approval to do these studies, and the FDA it's much harder to approve a botanical substance by the FDA, and yet we have some very brave souls in this audience who are trying to get the FDA to allow us to study natural product psilocybin mushrooms. Thank you. So hopefully we'll see that science happening soon. I'm excited to see that.
Great. All right, just going through more questions. Here's an interesting one. What about spiritual crisis as a conceptual framework for understanding adverse psychological states that persist after a hallucinogenic experience?
I find spiritual crisis or spiritual emergence to be a very helpful framework for thinking about what someone might be going through and what's the appropriate next step to help them. I also find it interesting that when I went back and read one of the original versions of, I think it was called Spiritual Emergence by the Groffs, one of their first steps that they recommended for when someone comes in to figure out if they're in a spiritual emergence is to go get laboratory tests and do a brain scan. Because they also recognize that there can be medical causes that look like what many of us would think is a typical spiritual emergence, and if they are having a brain bleed or if they are having a dysregulation of their electrolytes, that there are things that we should probably offer to help them with that medically. And yet at the same time, is there a spiritual emergence that can happen with serious medical illness? We see it all the time. So I think the big question is, what is consistent with that person's belief system? What is consistent with their community? Is what they're going through abnormal for their community's understanding of spiritual experience? That can be very helpful. And is it causing significant disability? I would love if we had what was pioneered in the 1970s and 80s in San Francisco, diabasis house, residential facilities where people could be cared for by staff who would assist them without any medications at all and work them through their process over time. But sometimes, frankly, that's not always safe, and staff and support people will get tired if someone is not sleeping for days on end. They're not able to take care of themselves, and sometimes medications can actually be very helpful, and hopefully we're providing both medication and non-medication support if they need it.
Thank you, Brian.
Thanks.